exceptional image quality. You want simpler workflows, intuitive, user-friendly technology, a better patient experience with improved patient outcomes. At Philips, we see the world as you do. Epic CVX, a dedicated cardiac ultrasound system designed for you. You need world-class imaging, clearer depth perception, greater insight, increased confidence, and better teamwork. Epic offers a dedicated solution for real-time fusion. You want an ultrasound system that lets you be your best. Anatomical intelligence with robust, reproducible quantification in an everyday workflow. This is Echo, the way it is meant to be. Scalable and ready for the future. And you want a partner you can trust, evolving with you. At Philips, we see the world as you do. The Epic CVX, designed for cardiology, built for better care. Philips, innovation and you.
Dr. Kapatret, can we begin?
Yes, we should.
Okay. Good day, everyone. Because now in Vietnam in afternoon, but in the United States, that in the night, in the midnight. So we are welcome to you to participate in a very interesting meeting. I would like to introduce my co-chair, Professor James Kirkpatrick. Professor James Kirkpatrick is from University of Washington School of Medicine, Professor of Medicine, and also Professor of Bioethics. So Dr. Kirkpatrick is a friend of so many of Vietnamese doctors and students in Vietnam. And I am Dr. Phạm Nguyên Vinh from Ho Chi Minh City. Today we will have 5 talks. I think every talk is very interesting one. So it is in midnight in the United States, so that Dr. Rigolin and Dr. Patin cannot answer the question after that, because it may be early morning in the United States. So for the first talk today, I would like to introduce Dr. Rigolin. Dr. Rigolin, she is Professor of Medicine in Cardiology. She from Northwestern University, Chicago, Illinois, and from Northwestern Memorial Hospital. Her interest is in echocardiography, valvular disease, and she is a member of ASCI Certification. She is the chair rising star task force for American Society today. So her talk today is about the futures of valve imaging. I'd like to introduce Dr. Rigolin, please.
Hello, my name is Vera Riglin, and I'm here to speak to you today about the future of valve imaging. Thank you for the course directors for inviting me to share this information with you. Now, we know that echocardiography is the primary tool used today for the diagnosis and management of valvular heart disease. However, as treatment strategies to treat valvular heart disease evolve, imaging needs to innovate in parallel. And with this, I predict that we will need improved image quality, increased quantitation, tissue characterization, multimodality imaging, appreciate the miniaturization of imaging ecosystems and what it means for the future of imaging, and then the incorporation of artificial intelligence. Let's look at an example of a typical patient that we see today. Here's a 50-year-old male with a history of a bicuspid aortic valve with aortic regurgitation who presents for follow-up. He feels well and exercises by running 25 miles a week. We see that he has aortic regurgitation, and by pressure half-time and the absence of diastolic flow reversal in the descending aorta, we conclude that the severity of valvular regurgitation is mild to moderate at the most. But then we look at the apical images and we measure his volumes, and we see that his left ventricle is severely dilated. So why would his ventricle be severely dilated if his regurgitation was only mild to moderate? And then we look at the volumes of his ventricle over the past several years, and we see that at least over the last 2 years, he's experienced a significant increase in the LV and diastolic volume index. So why would this happen if he only has mild or moderate regurgitation? So to answer that question, he underwent a cardiac MRI shown here. And by volumetric analysis of the MRI, we confirmed that his left ventricle is severely dilated. His ejection fraction is only 50%, which is actually lower than what was calculated on the echo. And by volumetric analysis, we measure his aortic regurgitant volume to be 65 mLs and the regurgitant fraction to be 43%. And this actually puts the severity of regurgitation into the moderate to severe range, not mild to moderate, which explains why his left ventricle is progressively enlarging. And because the left ventricle continued to enlarge, he was sent for aortic valve replacement surgery. And in follow-up, his left ventricle demonstrated a significant decrease in size, confirming, in fact, that the enlargement was due to the volume overload from the aortic regurgitation. So this is a good example on how multimodality imaging is helpful in cases that are a little bit tricky and the echo does not give us the complete picture. Now, over the last several years, we've had a boom in percutaneous therapeutic options for structural heart disease. And with that comes a boom in imaging, because imaging is essential for the diagnosis, for pre-procedural planning, for peri-procedural guidance, and for post-procedural follow-up. So now we have some of this incorporated into our most recent guidelines. If we look at how to manage mitral regurgitation based on the latest ACC AHA guidelines, we see that the guidelines divide us into primary and secondary mitral regurgitation. And why is that the case? That's the case because the treatments vary significantly between the two types of valvular regurgitation. For primary mitral valve regurgitation, if there are symptoms, a decline in ejection fraction of less than 60% or progressive enlargement of the left ventricle, transcatheter edge-to-edge repair for patients who are not surgical candidates, or surgery with either repair or replacement for individuals who are surgical candidates are the mainstays of therapy. On the other hand, for secondary mitral regurgitation, since this is predominantly a problem of the left ventricle, not of the valve, then our treatment strategies are aimed towards correcting the left ventricular dysfunction with medical therapies. And only after optimal medical therapy and device therapy do we consider intervening on the valve. So two vastly different treatment strategies, which is why it's important for us to identify which type of mitral regurgitation an individual has. So this is important for the present and even more so for the future. We need comprehensive assessment of valvular function. And with the case of mitral regurgitation, we need comprehensive assessment of anatomy, defining precisely the mechanism of dysfunction, and then being precise with our quantitative parameters. So here's an example of a patient who has severe mitral regurgitation who's referred for percutaneous therapies. The important imaging modalities in this case are the transthoracic and the transesophageal echoes, and the transesophageal echo is shown here. You see in the image on the left, you appreciate the left ventricle is dilated and there is systolic dysfunction, and this results in tethering of the mitral valve leaflets. So in this image, it looks like the mitral regurgitation is secondary in nature. However, when we look at our bicommissural view, we notice that in addition to the leaflet tethering, there's also a flail posterior leaflet that's contributing to severe mitral regurgitation as shown here. So this patient actually has mixed pathology, both secondary and primary disease. And the patient underwent successful mitral clip procedure or transcatheter edge-to-edge repair with 2 clips as shown here, with a significant reduction in the severity of mitral regurgitation. Now, there are patients with mitral valve disease that are even more complicated than this, and those are individuals who require valve-in-valve, valve-in-mac, or valve-in-ring procedures because of underlying dysfunction. In those cases, we need very precise measurements. We need the anatomy, mechanism, and severity defined by our echocardiographic techniques. But in addition, we need very precise measurements that can only be provided by high-resolution CT scanning, as shown in this example here. And in this case, we can even model the CT by overlaying the new prosthetic device to define other important measurements such as the neo-LVOT, which is the space that's created between the septum and the device once the device is deployed. And if this space becomes too small, left ventricular outflow or left ventricular outflow tract obstruction can develop. So measurements of this neo-LVOT or the predicted neo-LVOT after valve deployment based on CT images is essential for appropriate planning. So here's a patient that has severe prosthetic valve stenosis. You can see that the valve is barely opening. There's just a very mild amount of regurgitation, and you see on the 3D images here that the valve is severely stenotic, and this is proven by our Doppler quantitative techniques. This patient undergoes successful valve-in-valve procedures as shown here. You see that the leaflets are opening beautifully. And when we measure the LVOT gradient using transthoracic imaging, you see here that the LVOT gradient is normal and not significantly elevated. So our pre-procedure planning paid off. Now, there are devices that are becoming miniaturized, and this is a 3D intracardiac echo that was recently introduced. And this provides real-time 3D imaging through an ICE catheter. And this is a new technology that will revolutionize structural heart disease imaging, procedural planning, and is also useful in electrophysiology cases, as is in this example here, of a patient undergoing a procedure that required transeptal puncture. And you see how nicely the transeptal puncture is guided by the 3D ICE catheter shown here, and the ICE catheter images shown in the NPR views on the bottom of the screen. Now, what about aortic stenosis? Like mitral regurgitation, we have options for treatment. And in this case, we have surgical aortic valve replacement, and we have percutaneous valve replacement, or with TAVI. And imaging plays an essential role in trying to decide which patient gets what technique. So let's look at an example here. This is a 54-year-old female who presented with dizziness and near syncope. She has a calcified aortic valve, which turned out to be bicuspid in nature. And by our hemodynamic assessment, the severity of stenosis is severe. And when we look more carefully at her aorta, we see that the aorta is dilated. Keep in mind that she's a very small person, so when we correct the size of the aorta to her body surface area, we see that the aorta is significantly dilated. She underwent a CT scan to help better evaluate her aorta, and also with the decision making of whether or not she should undergo TAVR or SAVR. The CT scan confirmed that the aorta was enlarged, and particularly when you compare the measurements of the ascending aorta to the descending aorta, the ascending aorta is much, much larger, particularly given her small body size. Interestingly, we also found a small diverticulum in the outflow tract that was not seen on the echo. Based on this complex anatomy, it was opted to send her for surgical aortic valve replacement and replacement of her ascending aorta rather than undergoing TAVR. And this was all as a result of the multimodality imaging that was required prior to the final decision on what was the appropriate treatment for her. Now, so far we focused on looking at structure and function, but we really have to look beyond structure and function to be complete. Here's an example of another patient with aortic stenosis, and he has low flow, low gradient aortic stenosis. And we know how challenging those individuals may be. And sometimes even after you replace the valve, they don't get better. Well, in this case, this patient underwent a TAVR and really experienced minimal improvement in his symptoms, even though the valve was successfully deployed. And when we look at his strain imaging, we see that cherry on top configuration that suggests that he has cardiac amyloidosis. And this may explain why he did not experience significant improvement in his heart failure symptoms following the TAVR. Here's another study looking at what happens with the myocardium after long-standing pressure overload from aortic stenosis, and demonstrates that the left ventricle transitions from cellular hypertrophy to diffuse fibrosis to replacement fibrosis, and then ultimately heart failure and cardiac death. And we know even if we replace the valve, once replacement fibrosis has occurred, that the fibrosis does not go away, and that heart failure continues to ensue. So it's important that we understand the underlying function and structure of the myocardium in aortic stenosis to fully explain how patients will do after valve replacement is performed. Now that's a little bit of what we've done in the present and a little eye of what we have in the future. But let's look further ahead into what's in store in the future. And that is, in my opinion, the incorporation of artificial intelligence. This will aid us with interpretation of all aspects of cardiovascular imaging, which will allow for more accurate and reproducible image acquisition and interpretation. It's going to help us with structural heart disease device selection and sizing, and will assist with predicting complications, and will also help with education and training. Here's an elegant study that looked at computer modeling to predict aortic regurgitation post-TAVR. On the left-hand side of the screen, the computer model demonstrated for us the impact of device sizing. In this patient on the top, 2 different size valves were modeled, and there was really no significant aortic regurgitation with either valve size. On the patient on the bottom, however, the smaller valve resulted in more paravalvular regurgitation compared to the larger valve. And then device positioning is also important. In this patient here, the device is positioned a little bit lower in this example and a little bit higher in this example, and you see that the regurgitation was less when the valve was positioned slightly higher. The opposite was true with the patient on the bottom. Here, the amount of regurgitation was less if the valve was positioned slightly lower. So you can see that using these computer models, we can predict and appropriately plan for device size and position to minimize complications such as aortic regurgitation. Here's another model that demonstrates that we can't just look at paravalvular regurgitation, but we also have to incorporate the geometry and the mechanical properties of the device with that of the host. And here you see that in this model, we're predicting not only paravalvular regurgitation, but also the pressure contact of the device at different parts of the anatomic structure. Now, not every patient is complicated and requires multimodality imaging. Many require screening, really to find disease that is easily treatable, particularly those in rural areas that do not have access to medical care. And the screening can be performed with large-scale machines, such as on the left, laptop devices seen in the middle, or handheld devices on the right. And this is an image that was taken back in 2017 when the American Society of Echo was in Vietnam to assist with patient screening. And in this case, it was done with a laptop device. Now, this is an elegant study looking at screening for rheumatic heart disease that was performed in Fiji. And in this case, there were over 2,000 children that were screened for rheumatic heart disease using a simplified protocol. In this case, 7 nurses underwent 8 weeks of training on how to use a focused echo exam to screen for rheumatic heart disease. The children then later went to a reference center where they underwent a full echo by a pediatric cardiologist, and the 2 different echoes were compared. This comparison demonstrated that the nurses had a sensitivity of detecting rheumatic heart disease correctly of 84.2% and a specificity of 85.6%. So a good example of what small devices with mild amounts of training for non-experts can actually yield quite accurate results. And that now, if we combine artificial intelligence in these kind of devices, we can do even more. This was a study that was done at my institution, Northwestern, looking at the utility of a deep learning algorithm to guide novices to acquire echocardiograms for limited diagnostic use. And these were nurses that were trained in how to use the echo system, guided by artificial intelligence, to acquire the images demonstrated on the screen. And they were all successful in doing so with minimal amounts of training. So in summary, valvular heart disease affects millions of people worldwide. More options for treatment will continue to evolve, but echo will remain as the essential tool for diagnosis, treatment, and procedural guidance. However, multimodality imaging is frequently needed to best understand complex anatomy and function, particularly for individuals undergoing complex structural heart disease procedures. Artificial intelligence will be part of our reality and will help us reduce variability, improve quantitation, and be more accurate in our imaging techniques. Now, miniaturization of imaging systems will allow for expanded use of echo in non-traditional settings by non-traditional users, particularly when combined with artificial intelligence. So with that, I thank you for your attention and assure you that imaging for valvular heart disease has a very bright future, and I look forward to sharing it with you in the future. Thank you again for your attention.
Dr. Pangolin, for a very interesting lecture. Thank you.
It was a wonderful talk. Well, next I'd like to introduce my good friend, Dr. Jose Bunch. He is currently the director of echocardiography at the University of Colorado. He just joined their echocardiography department recently. He is a wonderful friend of Vietnam and of imaging in general. He spent many years directing the echo lab at MD Anderson Cancer Center in Houston and has been on the forefront of imaging in cancer care. We're very happy to have him come and speak to us on the innovation of echocardiography for risk assessment.
Hello, everyone, and thank you for the invitation to present at your conference. My name is Jose Bunch. I'm the director of echocardiography imaging here at the University of Colorado at the Anschutz Medical Campus, and for the next 20 minutes or so, I'm going to share with you some graphics and the topic of the utilization of echocardiography for risk assessment in a variety of conditions. I'd like to start by showing an EF-based analysis from the SOLVE trial. As you can tell, The left ventricular ejection fraction, as most of you know, it's a cardinal measure when it comes to echocardiography, and it's highly predictive of survival rate in this particular population with ventricular dysfunction. You can see how this is a very powerful measure that, divided even by 10% fractions, it's very predictive of survival rate on patients who were actually in pretty maximal medical therapy, and despite that, their survival rate was dramatically lower over time. And of course, those with the lowest ejection fraction would have the worst outcomes, highlighting the power of the measure and the echocardiographic significance of measuring ejection fraction accurately, and how that is beneficial for us to predict survival rates in these individuals. It's not the only measure, but obviously in patients that have known left ventricular systolic dysfunction, in this cohort, this particular study looking at those with ejection fraction already under 35%, how the grading of mitral and tricuspid regurgitation can also help us stratify who will have a better cumulative survival. On the right is the tricuspid regurgitation, on the left the mitral. So on these patients, we know that not having regurgitant atrioventricular valve disease is very significant. And so on those patients that have obviously severe MR or severe TR, as judged by echocardiography, these patients are the ones who are going to have a drastically lower survival over time. And this is in a study that included almost 1,500 patients. Another measure that has been utilized from echocardiography exams to value the survival rate of patients have been the measure of the pulmonary artery systolic pressure, which in echo, as you may know, is done by evaluation of the jet of tricuspid regurgitation. So in these patients already diagnosed with heart failure, in this particular cohort, again, a large volume, more than 1,000 patients, you see that those patients with the higher measure of pulmonary artery systolic pressure would have the worst prognosis, and in a 3-year period, the worst survival percentage. This is a constant. This is not the only cohort that has proven this. Pulmonary artery pressures in other studies have also been shown to correlate well with survival. And those, with those pressures closer to 60 millimeters of mercury, of course, are going to be doing worse than those with pulmonary artery systolic pressures under 40 or so. This is another example that combined that, not only the pulmonary artery systolic pressure, but the tricuspid annulus peak systolic excursion. On the left, just the combination of pulmonary artery systolic pressures and the movement of the tricuspid annulus, which is obviously correlated well with the systolic function or the ejection fraction even of the right ventricle. So in these patients on the left, those two measures combined had a very significant prognostic value. And so for risk assessment in terms of survival, again, those two measures combined were very powerful. On the right, they used the deceleration time and the TAPSE, which will, again, indication of right ventricular dysfunction or not. This patient's on a fairly recent study, a fairly large volume of patients too, with the ones with the worst deceleration time from the mitral E wave and the tricuspid annulus motion, were again the ones with the worst survival rates. So again, in these patients that already have in the community and have CHF, and in this particular cohort, an ejection fraction of under 45%, those with a pulmonary artery systolic pressure above 40 and tricuspid annulus peak systolic excursion under 14 millimeters, very significantly decreased prognosis compared to those with high pulmonary pressures, but preserve TAPSE, and very clearly shown on the graph on the left. So TAPSE, a very now prominent measure in cardiac exams, and very easily to obtain by tracing a line, an end-mode line over the tricuspid annulus, and when we see that excursion surpass here roughly a 1.7 millimeters in distance, and that is what we will call normal, so 1.7 centimeters or more. Of course, many trials that have looked at heart failure, patients with the known systolic dysfunction. In this case, the well-known BEST trial, the subgroup analysis of volumes, and again, left ventricular systolic volumes are a very powerful measure also for prognosis. So this is another way where truly simple echocardiographic measure can provide us very significant time to death, in this case, information. So these patients using a left ventricular diastolic volume index proved to be a very powerful predictor of death. Those patients with a left ventricular end diastolic volume index of under 120 millimeters per meter square had a clear advantage to those where the volume was higher. And this was a very large study where they compare measures on groups between placebo and treatment with beta blocker bucindolol. There in detail, the graph separating the volumes. So that's why, and other reasons why the left ventricular end-systolic volume index should be prominently featured in our echo reporting. The normal for male and female, as shown in this table that came out in the Journal of American Society of Echo, most recent left ventricular quantification guidelines. In the BEST trial also, they looked at deceleration time from the E wave, and clearly the pattern of filling as described by deceleration time had a significant impact in survival. These patients with a reduced deceleration time, usually meaning less compliance of the ventricle, also having a significant separation for those right at the point of 150 milliseconds. So those with a short deceleration time under 150 milliseconds with a much different prognosis than those with deceleration times above 150. In this particular group also, they had mitral regurgitation. The vena contracta width had an impact in overall prognosis as well. In this case, dividing the vena contracta width of MR by 0.4 centimeters up and above. Just to point out that in that particular trial, the ischemic cardiomyopathy cohort was right around, it was a majority, but not a large majority. So this encompassed, patients with other clinical syndromes other than the ischemic disease. In other measures that have been obviously more modern, using three-dimensional volumetric analysis, real-time 3D echo and 2D Doppler echo were performed. This in about 100 and so patients where they were already classified and known to have significant left ventricular systolic dysfunction. They were all in sinus rhythm, but if they had an ejection fraction of under 35%, they were included in the study. And as you can tell, a left atrial volume by 3D measures of above 100 correlated very strongly with event-free survival, in this case, hospitalization for congestive heart failure symptoms and also overall mortality. So in these patients, this is a measure to watch for too, and we obtained it very well with biplane, but in this particular study, they looked at it on 3D, which is a pretty easy and feasible measure. In these patients with known systolic heart failure, another thing that have been evaluated and correlates with a study I showed earlier was the pulmonary artery pressures. In this particular study, is just a cohort of 89 patients with known ejection fraction under 50%, and they follow them for a total of 48 months. So they look at an endpoint of composite of death and heart transplantation or hospitalization for acute decompensated heart failure. And both the ejection fraction by real-time 3D under 35% was predictive of event-free survival rates, as well as the pulmonary artery systolic pressure, with the pressures there divided by above and below 46 millimeters of mercury pressure. Another thing, obviously, that helps us in terms of evaluation is contrast. In the patients with heart failure reduced ejection fraction, obviously looking at morphology of the ventricle, volumetric assessment is much better with the use of microbubble enhancement, but the presence or not of thrombus is one thing that we have been very thankful for the imaging technology of microbubble enhancement, since very clearly to see it, in this case, a very large mural apical thrombus in the apex. And we had studied this in a cohort in our own group. We're looking at almost 700 patients with severe systolic dysfunction and trying to predict and know what was the risk of having a clot, and intuitively looking at how they're presenting, the echoes were able to help us determine that, because it turns out that the lowest end of systolic function and also the worst of diastolic filling pattern help us tremendously separate the risk for clot formation. So we found that having an ejection fraction under 20% and having the worst pattern of filling, the restrictive filling pattern, was associated with a higher risk of finding apical thrombus. It helped us tremendously in this particular population. So now it helped us to determine that these patients at the high risk of clot were those with the lowest quintile of ejection fraction, but also the risk was much higher when that was accompanied by a restrictive filling pattern. One of the newest things on the echo horizon has been obviously speckle tracking echocardiography, and this technique produces very dramatic images with color, where we obtain polar maps, in this case longitudinal deformation only, maps that give us a deformation pattern. In this particular case, on the top left, you see a patient with very increased thickness, and it could have been a different pathology, but when we see this apical segments having much more normal values than the mid and the base, we can help us determine that this, or hint to us that this is most likely an infiltrative type of cardiomyopathy. On the bottom left, the pattern is of total opposite. The ventricle may not be fully visible to us with the naked eye, but then when we obtain this data, we can clearly see that, confirming to what we were perhaps suspecting, that the apex was completely dysfunctional. So the pattern really hits you in the face that there is something here to clearly separate the functionality of the different segments of the ventricle. So this technology, the speckle tracking echo and the valuable longitudinal deformation of GLS, have been used to predict mortality. In this particular cohort from the study in 2009, 542 patients were followed for almost 5 years, and the information obtained by baseline clinical characteristic and the GLS was far more powerful to determine the death prediction than baseline with wall motion score index, and that was better than baseline with just ejection fraction, and obviously that's better than their baseline clinical characteristics, which were age or presence or not of diabetes and hypertension. So again, a very powerful measure, the GLS, to include in our clinical assessment and for risk prediction as well. This is just a small presentation we had from our group when I was at MD Anderson, where we found very clearly the pattern of apical dysfunction on GLS polar maps to differentiate and help us on these patients who presented to the emergency room with seemingly coronary syndromes to quickly determine that the differential diagnosis was more in the area of stress-induced cardiomyopathy, and so different risk pattern obviously than typical coronary syndrome. So one way to have a risk assessment also from the get-go is to obtain speckle tracking global longitudinal deformation measures and the polar map as well. So one more use for this have been more recently to use the global longitudinal strain in heart failure patients, those who were submitted for resequencing therapy. In this particular cohort, little over 100 patients with heart failure, which were treated with CRT. They did an assessment before CRT implantation, and you can see how the GLS alone predicted very well in terms of the combination of all-cause mortality, heart transplantation, or LVAD use. Those patients in the worst quartile of GLS, those with the GLS of negative 5.8 or mathematically higher, were the ones from the get-go with the worst prognosis in terms of that meeting that primary endpoint. So even moving to CRT, again, another powerful echo measure to assess risk of future mortality, transplant, and LVAD utilization. Just to emphasize again a little bit on these patients with the infiltrative disease, one of the worst cardiomyopathies we find in patients with a very sharp early mortality. This patient on the left would not reveal the classic presentation, but showing more of an apical presentation, clearly indicating that there is a certain risk on these patients. And echocardiography, very, very classically has been used, particularly filling characteristics like the ENA and the deceleration time are used on these patients with infiltrative disease to determine risk and overall mortality. And this classic paper, mainly the deceleration time, right at that cutoff mentioned earlier from the heart failure, other heart failure cohort that I mentioned in the slides previously, the deceleration time of under 150 milliseconds, particularly notorious to be a high risk indicator in these patients. And it's been defined, this has been books, this has been in older literature, that a restrictive mitral inflow pattern on patients with amyloid infiltration in particular have a much worse 1-year survival rates than those without such a deceleration time. Also, the echo features of hypertrophy per se, and with symptoms of those with clinical heart failure, have a very poor 6-month survival rate. Using it for overall prediction in the case of particularly of amyloidosis, it has been shown that the separation from apex mid cavity and base values have a prognostic value. As I've alluded to earlier, these patients have the apical preservation, but when those patients have a strain abnormalities on the base that is reduced or mathematically higher than negative 13%, this was when they were doing strain based on Doppler. Well, those patients have obviously worse risk when it comes to all death and cardiac deaths as well. That the cardiac deaths in particular with a number of minus 12%. So the measures of the GLS obviously stand as a powerful risk value in and of itself, but the patterns can help us tremendously when it comes to separating differential diagnosis. All these patients on the top are patients with the infiltrative condition, and even though all patients had similar ejection fraction, similar LV mass calculation, you can see how these have a much different pattern where the base septum is affected. These are patients with hypertrophic cardiomyopathy, and this have more patchy deformation abnormalities, and these were patients with aortic stenosis, and secondary to that, their mass and their ejection fraction changes. Just to illustrate how that is also kind of a plastic measure, if you will, on patients with infiltrative disease. This patient with a pretty normal polar map, all red, all normal values, and with the diagnosis of amyloidosis and waiting for a stem cell transplant, patient unfortunately got sick with the pneumonia, and very quickly, within a month, the patient in the ICU sick with the same ejection fraction, but the pattern showed a significant abnormalities around the mid cavity and the base, patient manifesting clearly that there was some toxicity related to the infiltrative disease that was already present and hiding in clear sight, but we were able to see it with the deformation pattern itself. And then patient recovered, and quickly this all normalized. The patient didn't really drop the ejection fraction, but in follow-up and closely after transplant, stem cell transplantation, patient clearly showing normal values. Another case just to show that there is hope on these patients that get transplanted early in terms of stem cell transplant. These patients start with a very critically low longitudinal average, but quickly after transplant started to improve, and we saw that value from 6.4 jump to 7.2, later to 10.9, and almost 11 here in follow-up. And now, even though it was still 11, you can see how now everything is improving. In this patient, those values correlated pretty well with his 6-minute walk. It started at 300 meters, and at the end, he was when he was at a value of GLS of 11, already able to jog, and you see just a modest increase on ejection fraction. So a much more dramatic orientation of his walking capacity with the big jump on GLS. So one thing is the value itself, and I already showed how that's related to risk and overall prognosis, but the patterns recognition itself very useful for the clinician because of the colorful presentation and how it helps in terms of the differential diagnosis. We can recognize that there is obviously segmentality to this polar map and how each artery has its own patterns. Is very easy to recognize. This is a publication, classic now from the 2007, but these are my own patients in clinic with the same here, LAD, proximal LAD disease pattern, proximal circ complex occlusion, this patient with a chronic occluded RCA. So pattern of normal, pattern of apical preservation serves very well to identify those patients with infiltrative disease. The pattern of apical, isolated apical deformation that could hint us at stress-induced cardiomyopathy, or the classic Takotsubo finding, proximal AV disease appearance, proximal circumflex appearance, RCA appearance. I want to show one case in the last of my slides, a patient that presented to me in consultation, 71-year-old man who had prostate cancer, local disease, and had a prostatectomy and had an abnormal cardiac test history. I had to clear him for surgery. And he was asymptomatic and anxious to have the prostatectomy. I had no records available for me to review, but with a cardiac history of a procedure to fix something many years before. And the echo seemingly didn't show a drastic abnormality. That it was almost to be read as normal, actually, but clearly had some base inferior posterior abnormality on the pattern of the RCA. And me, without having records, we're very thankful to have his GLS at minus 15.4. Had to clear him for surgery without records. And as you can tell, in patients who've had, even if he had the worst of myocardial infarction, the STEMI, those patients that have GLS more than 14 and on follow-up more than 13 are the ones with the best prognosis. So him at 15 indeed was going to be in the best of category for risk assessment. And in this particular case, of course, I let him, he was asymptomatic, so I let him go for surgery and did very well. So one of the things to be used perhaps also in the pre-operative risk assessment on these patients, particularly with the history of coronary artery disease. So in summary, as you can tell, starting from ejection fraction all the way to the newest techniques of speckle tracking imaging, echocardiography is extremely useful for high risk and recognition in multiple cardiac settings, especially cardiomyopathies, particularly heart failure of reduced ejection fraction. And it has clear clinical outcome relevance, when we're talking about measures like the ejection fraction, the LV volumes, the LA volumes, as I showed slides of the case for 3D, RV function, also mitral intracoustic regurgitation has been well characterized as risk recognition measures, and also in the new, there's a lot of new studies coming on to show GLS also, but a variety of echo measures for prognosis and risk in structural interventions. And this is my last slide. Thank you again for having me present in your meeting, and I hope I was able to share some new knowledge with you guys. Thank you.
Thank you, Professor Joseph Panch, for your very excellent lecture for us. Now, I would like to introduce Professor Wyman Lai. Professor Wyman Lai is currently now co-medical director of CHOP Children's Health Institute, clinical professor of pediatrics at the University of California, Irvine. His specialty is echocardiographic description of complex congenital heart disease. Professor Lai have held so many young doctor pediatric cardiologists in my hospital to show some presentation in the case. So today, Dr. Lai will talk about innovation of echocardiography for congenital heart disease. Professor Lai.
Hello, and thank you to the organizers for inviting me to speak at this hybrid meeting of the Asian Society of Cardiovascular Imaging. The field of echocardiography for congenital heart disease is advancing rapidly, benefiting from innovations that service a broader segment of medicine. I will briefly discuss 3 innovations that I believe will have the greatest impact in our field over the next decade. An innovation that has already arrived is point-of-care ultrasound, or POCUS. Next, an evolving tool, 3D echocardiography, and lastly, I will present some of the early developments of artificial intelligence. Beaton, Sabo, and colleagues demonstrated that the technology of handheld ultrasound was adequate for diagnosing children with features of rheumatic heart disease, with screening provided by pediatric cardiologists, pediatric cardiology fellows, and cardiac sonographers. They looked at 4,773 children in Uganda. Paired echocardiograms were performed in 1,420 children. 133 of these cases had borderline rheumatic heart disease, and 47 had definite rheumatic heart disease. They found that the sensitivity of handheld ultrasound compared to a standard echocardiography was 79%, and specificity was 87%. The importance of training is evident by looking at these 2 studies. In a small study of 54 patients, Thomas Mota and colleagues showed that there were important interpretation errors by novice pediatric emergency medicine fellow sonologists. They had a sensitivity of only 50% while achieving a 100% specificity for diminished ventricular function and similar numbers for pericardial effusion. In contrast, Miller and colleagues showed that in a study of 1,241 patients, expert cardiac POCUS sonologists and PEM attendings had 100% sensitivity and nearly 100% specificity for both LV systolic dysfunction and pericardial effusion. Cardiac POCUS is an important innovation for the diagnosis of congenital heart disease in resource-limited settings. In a study from the Doctors Without Borders group, the utility of cardiac POCUS was examined by looking at 233 cases. All the studies were performed by novices to echocardiography. Of the 191 cardiac POCUS studies performed, a cardiac diagnosis was possible in 163 cases, or 85%. This is a list of the diagnoses that were made. 33 patients were normal, or 17% of the total population. There were simple heart diseases found, such as atrial septal defect or ventricular septal defect, common atrial ventricular canals or atrial ventricular septal defects, tetralogy of Fallot, and other more complex diseases, such as double outlet right ventricle or transmission of the great arteries, and single ventricles with complex lesions. Cardiac POCUS, therefore, is an important innovation due to its benefits of accessibility and speed of diagnosis. Its barriers to adoption include cost for many resource-limited countries, the need for training, and the ability of a congenital heart disease expert to perform that training, to read the studies, and to perform the necessary quality improvement and retraining of the sonologists. 3D echocardiography is a modality familiar to many of you already. One of its strengths is the ability to acquire accurate 3D volumes for assessment of ventricular function. In a meta-analysis of 12 studies that reported both 3D and 2D echocardiographic LV volumes, we see a comparison of 3D in green and 2D in red values, in contrast to the cardiac-derived MRI values, which are shown in solid lines. The column on the left is are the values for LV end diastolic volume, in the middle end systolic volume, and on the right ejection fractions. Not only were the mean 3D values in general closer to the CMR values than the 2D measurements, the standard deviations are less, which makes 3D echo both a more reliable and a more robust measurement of 3D volumes and 3D ejection fraction. The value of 3D echocardiography is easily seen in congenital heart diseases such as an atrial septal defect. With a 3D TEE, one can see the size and location of the defect, the size of the surrounding rims, and the adjacent structures. When using 3DE, one can easily help guide intervention. In atrioventricular canal defects, the value of 3DD is for surgical planning and to help to assess the residual defects. Here, one has the X-plane showing you the area of the 3D image and then the full 3D image. These magnificent images are from an incomplete atrioventricular septal defect or a primum ASD with a cleft mitral valve. When looking at the defect, one can see the mirror leaflet and the cleft with a superior and inferior bridging leaflet. This image here is taken from an infant with a complete atrioventricular canal defect, Rastelli type C. The important thing to note here, and I should note that this is a TE obtained from a pediatric probe that is not yet commercially available. But one can see with the detail that there's a single papillary muscle on the left ventricular side, an absent mirror leaflet, and one can warn the surgeon not to close the cleft so much as to cause mitral stenosis. With advances in software, fusion of images from multiple imaging modalities now make it possible to perform more complex procedures in the catheterization laboratory. The 5 top diagnoses referred for routine 3D echocardiography in advanced laboratories include mitral valve anomalies, aortic valve anomalies, atrial defects which require TEE for interventional guidance, complex common AV canal, and complex double outlet right ventricle, which require baffling from the left ventricle to the aorta. 3D echo, therefore, has benefits in accuracy and reproducibility of ventricular function assessment. It has more spatial information for septal defects and baffle pathways, and it can provide detailed valve morphology for surgical planning and the assessment of outcomes. Barriers to adoption include image quality, that is, the trade-off that is necessary for spatial versus time resolution, the need for miniaturization of probes, display limitations, and availability in terms of cost and expertise. I want to take the remainder of our time to review the 3 potential roles for artificial intelligence in pediatric cardiology imaging and to share with you our experience in this field. AI can be used to augment the diagnostic acumen of physicians. When used appropriately, AI should make doctors smarter, not dumber. Second, AI technologies can facilitate image acquisition and optimization. And third, AI has the potential to improve education and training in all areas of cardiac practice. When developing AI models, data scientists naturally turn to the human brain as a source for guidance. Neuroscience has taught us that cortical networks exist in the brain, with rich sets of connections, including local and long-range lateral connectivity and top-down connections from high to low levels of the hierarchy. Similarly, complex AI models now depend on deep networks with successive layers of neuron-like elements connected by adjustable weights called synapses after their biological counterparts. Using artificial neural networks, or ANNs, machines are programmed to learn by receiving input either in a supervised or unsupervised fashion. These inputs, or data, are processed through multiple layers of analysis, looking for features, associations, and plausible inferences. The more layers that exist, the deeper the network. The final step is to provide an output or answer to the question. AI seems poised to play a significant role in the field of fetal echocardiography. Semi-automatic AI techniques can be used to depict standard imaging planes using 3D datasets. The FIND technique has been shown to be reliable and easily learned. Beginners demonstrated marked improvement with only 4 weeks of training. Other groups have published improved CHD detection rates. In a remarkable study using 107,823 images from 1,326 retrospective screening fetal echocardiograms, a group of UCSF investigators trained in an ensemble of neural networks to identify 5 recommended cardiac views with excellent results. Their segmentation ability rate was an area of under the curve of 0.94 to 1.0. They were further able to train the neural networks to distinguish between normal hearts and complex congenital heart disease with remarkable accuracy, achieving an area under the curve of 0.99 with internal test data and an AUC of 0.89 with external test data. More studies are needed to determine the utility of their ensemble learning models for population screening. Nevertheless, this study demonstrated that future programs for improving the detection of fetal congenital heart disease are likely to include AI-assisted image acquisition and interpretation. At Chalk Children's, in partnership with the UCI Center for Artificial Intelligence in Diagnostic Medicine, we embarked on a program to demonstrate the utility of AI in the diagnosis and treatment of neonates with patent ductus arteriosus, or PDA. Our first step was to train a neural network to accurately make the diagnosis of a PDA on echocardiography, a relatively simple task for a cardiology fellow in the first year of training. We trained a network with single echocardiographic video clips lasting several seconds. The selected clips were ductal views with color flow Doppler over multiple cardiac cycles. A total of 275 de-identified video clips across 176 patients from our neonatal intensive care unit were used for training, and an additional 73 clips from 73 neonatal patients were used for testing. Video frames extracted from the clips were analyzed as independent images or image sequences. We explored the use of various convolutional neural networks, or CNNs, for analysis of frames as independent images, and various temporal convolutional networks, or TCNs, for image sequence analysis. Our preliminary results look promising, with better results achieved with CNN algorithms than a TCN model. The CNN algorithm that worked best had an AUC of 0.93, but it required the manual removal of non-PDA frames in our training data, an example of time-intensive supervised machine learning. AI has significant limitations and challenges. The challenges include image quality, the vast amount of data that's necessary, so data quantity and sample size, cost of development of infrastructure, privacy and other medical legal issues, and the cultural acceptance of AI in the role of medicine. Technology may play a role in solving the problem for the need for a large amount of training data. Using a progressive generative adversarial network, or GAN, synthetic cardiac magnetic resonance images can be generated as shown here. From Diller and colleagues, we see that this top row is synthetic data, which are synthetic images generated from actual CMR images in patients with tetralogy Fallot, have the highest degree of statistical similarity. Better data quality can also be generated with AI assistance, further enhancing the ability to make accurate diagnoses. Using echocardiography, deep learning programs can effectively remove noise from 2D still images. Gradually, we have become surrounded by ultrasound systems and computer tablets that are incredibly intelligent. Our echo machines optimize images for us, and its software can reliably perform most volumetric measurements with good accuracy and reproducibility. Soon our trainees and novices will be performing studies guided by software. And future generations will be exposed to countless pathologies and practice complex surgical techniques in the world of virtual reality. Artificial intelligence in echocardiography has significant potential benefits. That of diagnostic accuracy without fatigue, and the guidance of image acquisition and training. The barriers to adoption remain its current technological limitations, the cost of developing the AI infrastructure, and cultural acceptance. I'm thankful to have had the chance to talk about the innovations of cardiac POCUS, 3D echocardiography, and artificial intelligence. I want to acknowledge Drs. Folger Meisbaum and Penny Joan, who provided many of the wonderful 3D images that were shown. I'd also like to thank Drs. Anthony Chang and Howard Lee, my AI collaborators at UC Irvine and Chalk Children's. Thank you for your attention, and I'm happy to answer any questions.
That was truly a wonderful presentation by a true innovator and a wonderful educator who's given so much to so many over so many years. Thank you so much, Dr. Lai. Well, let's turn now to Pravin Patel. He is Associate Professor of Medicine and Cardiology at Temple University School of Medicine, and he directs the cardiovascular disease training program there. And he also participates in medical student education as well. We're very fortunate to have him come today from Philadelphia via a virtual presentation to discuss innovations of echocardiography and cardiac imaging in preventive cardiology.
Thank you for the opportunity to present to you today some of the most interesting innovations in echocardiography and cardiac imaging. I hope you will find it interesting and have takeaways to take back to your own practice. My name is Praveen Patil from Temple University in Philadelphia in the US. I'm Director of Cardiovascular Disease Training Program here and I'm Associate Professor of Medicine. I don't have any relevant financial disclosures. So, as I outline some of the most interesting innovations in imaging, in particular of echocardiography, I'll start with something you're probably more familiar with, like myocardial mechanics or strain imaging. Then move on to some more interesting topics like a novel blood speckle imaging technique, as well as some of the fused cardiac imaging attempts we've made in our structural heart disease program here at Temple, and hope you'll find numbers 2 and 3 very interesting. So it's important to remember that in terms of echo, while the ultrasound probe may be quite different from case to case, from machine to machine, the cart is equally important. There could be machines that are able to do 3D interpretive, fusion technology, myocardial mechanics, 3D strain, twist, and so on, all the complexities. And then there may be others that can interface with cath labs in terms of co-registration and so on. And at the more simple end, an ultrasound probe might be attached to a handheld echocardiogram or a tablet-based or something that could be readily used at the bedside in terms of point of care. So let's begin with the first of 3 interesting innovations in myocardial mechanics and strain imaging. While strain has widely accepted in terms of cardio-oncology, a more recent application, or shall I say, a more widely based application is in HFpEF and characterizing cardiomyopathy. So I'll begin with a 76-year-old male who in March of 2014 underwent a redo hip replacement. Prior to that, he was active, exercising, hunting, and then post-operatively, he was very short of breath, walking up hills. He figured it was just deconditioning. He figured he was at high altitudes and he needed a couple of minutes of rest. He didn't have any renal disease, no anemia or neuropathic symptoms. On review of systems, he was short of breath. He was dyspneic on exertion. He had 2 pillow orthopnea, easy bruising, nocturia, and some depressive symptoms. He underwent a serum workup for cardiac amyloid, given some of the echo imaging that I'll show you, and that was negative. So on echocardiography, demonstrated increased LV wall thickness. Note I said increased LV wall thickness rather than LV hypertrophy. And the cavity size remains normal, and the LV function is at the lower ends of normal. He underwent strain imaging by speckle tracking echocardiography. And on strain imaging, you can see in the bullseye in the lower right corner, you can see that there's apical preservation of myocardial strain, whereas the values quickly taper off as you pair to the base. Looking at it in terms of segmentally, and you can see that this apically preserved area is what some might term cherry on top, or significantly consistent with an infiltrative cardiomyopathy or cardiac amyloid. This pattern, though, it may point towards cardiac amyloidosis. It does not specify whether this is AL amyloid or TTR amyloid. This patient underwent a cardiac MRI, which revealed normal LV size, mild concentric increase to LV wall thickness, normal RV size and function, also incidentally mild descending aortic aneurysm and moderate biatrial dilatation. But what was most interesting was the presence of late gadolinium enhancement in this case, where there's difficulty nulling the myocardium, which is an inversion recovery technique used in MR. And if you look from a paper by Dr. Syed in 2010, it's the different patterns of late gadolinium enhancement that might be present in cardiac amyloid. You can see that our patient ended up with example B, where there's difficulty nulling the myocardium, and you can see the blood pool is dim in this image as well, as opposed to the others with bright blood pools and dark LV myocardium and focal areas of scar. So what were we left with then after cardiac MR? We're still undecided as to whether this is AL or TTR amyloid. So we looked at the technology. In this case, the patient underwent a technetium 99 pyrophosphate scan, so a infarct avid imaging, which has been incredibly useful in terms of diagnosing TTR amyloid in our patients. And in this case, the planar imaging showed significant myocardial uptake, not in the blood pool, myocardial uptake, even on planar imaging, it's quite evident. And our guidelines suggest looking at the heart to contralateral ratio, so draw a region of interest over the two areas and look at the ratio. And in this case, the ratio being 1.9, it was significantly positive for TTR amyloid. This is a very specific study and highly useful. In this case, we are also able to do SPECT CT fusion, which helps us to see that uptake in the heart and be certain that it's not pyrophosphate still in the blood pool, but rather uptake in the myocardium. And you can see that on these images where the uptake is in the myocardium, and CT is our registration. Oftentimes, people present positive images, and it's difficult to compare to what would normally look like. Well, let me show you what a normal patient would look like. In this case, there was no uptake, and no uptake on this registered image with CT and pyrophosphate, suggesting this is grade 0 and not consistent with TTR. But our patient was positive for TTR. And so it's interesting technology, the myocardial strain, but that echo does not exist in a vacuum and that it needs to be incorporated with other imaging modalities. So it's really that multimodality imaging is the key. Patients will often require multiple imaging studies to establish a diagnosis, and echocardiography is the gatekeeper test. Hopefully this case demonstrated how the innovations in echo led us down a disease pathway and led to other modalities that were eventually diagnostic. Imaging features of amyloid by echo and cardiac MRI are diagnostic, but they're non-specific. We weren't specifying between AL and TTR, and that necessitated a multimodality approach. And only after the pyrophosphate scan were we quite certain that this was TTR amyloid, or the C9 wild type. So, TTR amyloid, it could be a whole separate discussion, but, it's an emerging novel disease. It's an emerging, it's a disease that has emerging novel therapies that are disease modifying. And it increases the urgency to diagnose it at an early stage so we can offer our patients therapies. All right, so a little bit of myocardial strain, a case of amyloid, and multimodality imaging with pyrophosphate and MRI. I'd like to move to the next interesting innovation in echo that may appeal to you, and that is blood speckle imaging. So conventional echocardiography, we're accustomed to reading 2D imaging, looking at M-mode echocardiography, looking at color flow Doppler for regurgitant jets, areas of obstruction, and so on. And then using spectral Doppler techniques to measure velocities and slopes and pressure half times, or using tissue Doppler to measure velocity of the myocardium as we assess things like diastology, or perhaps assessing an S prime and the RV function. What I'm more interested in, and I showed you just now under myocardial mechanics, speckle tracking echocardiography, I'd like to shift our paradigm a little bit. In all of this imaging, we were focusing on the muscle and using Doppler to assess the blood pool. Or in speckle tracking echo, we were focusing on the myocardium and its mechanics and its strain and strain rate, and mean global longitudinal strain or apical preservation and so on. Let's shift now and consider the possibility that we could do speckle tracking echocardiography of the blood pool. The blood pool. So there is backscatter of ultrasound from the blood pool. It's something we generally ignore. As techniques advance in echocardiography, we're learning ways to assess that blood pool and its flow. So now I've mentioned the word flow. You may be more familiar with looking at four-dimensional flow characteristics by cardiac MRI, a novel technique as well. Four-dimensional flow MRI allows us the ability to look at images, color images, overlaying cardiac anatomy to assess stenotic, regurgitant jets, and so on. I liken this to color flow Doppler, again based in the limits of temporal resolution. But additionally, this phase contrast now, not a separate MRI talk, but phase contrast imaging in a specific plane can allow us to look at the vortex type flow of the blood pool. Okay? This is sort of a basic understanding of 4D flow MR, because I want to talk to you about blood speckle imaging in echo. So this allows us to see the flow in a way that we haven't seen before, especially in different disease states. So blood speckle imaging echocardiography is actually a novel technique to assess those same fluid dynamics. We're trying to demonstrate the vortices and laminar and turbulent flows that occur within the heart. And then, unfortunately, the technique and all of our techniques are dependent on high frame rates. That is the golden rule. Or the high frame rates are what dictate the quality of our images. And so blood speckle imaging, speckle tracking of the blood pool, was actually initially demonstrated in pediatric patients. And it has a similar visualization to 4D flow CMR, but in no way whatsoever is it nearly as quantitative at this point or physically based as the 4D flow CMR example I showed you. That's more just a corollary. So I'll show you this paper briefly where a pediatric group looked at blood speckle imaging as a new echocardiographic approach to looking at fluid dynamics in congenital heart disease. Dr. Borelli and colleagues demonstrated this in a number of different pathologies, including AV septal defects, suspicious flows in pulmonary arteries, aortic stenosis, and even hypertrophic cardiomyopathy. Ability to look at the fluid dynamics was the key in this evaluation. So this piqued my interest. If you look back to Da Vinci, the aortic valve was an obsession, and the mechanism of flow was the even greater obsession. Looking at the drawings of flow through the aortic valve that Da Vinci assembled, and the vortices that formed within the sinuses of Valsalva, as he described, it's strikingly similar to what we see in blood speckle imaging. Da Vinci actually used a glass model of an ox's aortic root through which he pumped a mixture of grass seeds suspended in water so that he could visualize the vortices. So on our example here, I have a 2D and a simultaneous color flow blood speckled imaging demonstrating the flow out the aortic valve and the vortices that occur within the sinus of Valsalva. The corollary to the Da Vinci drawings and really sort of confirming those same postulated mechanisms. If you now think back to the 4D flow that I showed you by cardiac MR, this is strikingly similar and a novel look at this, the flow of blood pool speckles. But of course, if I'm going to show you a normal, I might as well show you the stenotic. And unfortunately, as the valve becomes more stenotic, the total kinetic energy changes as the velocity of flow of the blood through the aortic valve changes, as well as some limitations of shadowing and so on, resulting in energy loss and altering the vector formation, or the vortex formation, rather, I should read. And as that happens, you can see the pattern of flow is quite different in the ascending aorta, quite different. If you apply the same concept to how our left atrial appendage is empty, rather than them being simple directional velocities of the appendage emptying into the LA, it appears that it's more of a vortex or sort of like a tornado emptying into the LA. And you can see this in two different patients, as the vectors in gold demonstrate the flow as the left atrial appendage empties. So really, if you think about it, it's actually adjunctive data to how we assess left atrial appendage emptying velocities, which we typically do by pulse wave Doppler. But clearly a direction-dependent entity, it would be interesting to see how this omnidirectional parameter, like blood speckle imaging, allows us to add to our 2D color flow and spectral Doppler assessment. It clearly needs further investigation, and that's why this talks innovations in echocardiography, but it also needs standardization in terms of what we're visualizing. And hopefully, some quantitation of these vectors can allow us to make better, more reproducible assessments. In this case, I showed a left atrial appendage occlusion device, a Watchman device, and used the blood speckle imaging technique to look for any flows that might be peri-device. So there are a number of potential applications, and I look forward to seeing how blood speckle imaging changes over the coming years. And then finally, one of the topics near and dear to my heart, fused cardiac imaging, has clearly been an innovation in echocardiography and CT in the realm of structural heart disease. Think back to augmented reality when it was first coming on the forefront. It's basically taking an interactive real-world environment where objects are augmented by perceptual information. Basically an overlay of sensory information. It's, in essence, enriching your perception. So if we use augmented reality in the cath lab, I'll give you an example that, of a 79-year-old woman with rheumatic mitral stenosis who had a bioprosthetic mitral valve. She had dyspnea on exertion, she had a hemolytic anemia, and she had a mitral valve with paravalvular leak. She had a haptoglobin less than 6, and she had a paravalvular leak along the medial aspect of the septum. She was referred for transapical paravalvular leak closure. So transapical, because it's so medial, it would be difficult to come transeptal and bend back to close this with a closure device. So we took this approach in terms of fused cardiac imaging and took the opportunity to fuse CT data with fluoroscopy. And so we had the fluoral projection of this bioprosthetic valve. And we had the cardiac CT that helped us identify the extracardiac structures as well as the intracardiac abnormalities and pathologies. As we fused these two, and during the intervention, you can see landmarks that we dotted in yellow, highlighted in the CT, become live dots on the fluoroscopy image. So in summary, what we did is we took a CT, we segmented for different anatomy, we identified where we would want to puncture the skin, where the LV apex was, and then where the paravalvular leak was. By co-registering common anatomical elements in two projections, we were able to fuse these images, and all of a sudden these dots are now live on our fluoroscreen. And you can see we punctured at the skin, lanced the apex, ended up within the LV cavity, and this wire crosses through the paravalvular leak. Eventually, we deployed a closure device, and you can see that closure device delivered here immediately on esophageal echo. And from the LV perspective, you can see it delivered here. So certainly a success, and basically we reviewed fusion CT imaging for paravalvular leak in our institution over a 2-year period where we did 6 cases. There were different approaches, transapical, transeptal, retroaortic, and a variety of different valve prostheses as well. The most common indication was hemolysis, like this patient. And the CT, paravalvular leak sites, correlated well with TE, and the site of wire crossing, like I showed you in this example, correlated in all the cases. Although technical success varied, about half of the cases resulted in no significant PVL afterwards. So certainly success in terms of using fusion CT imaging. But this is a talk on innovation in echo. And perhaps in your lab you have the ability to do the same type of co-registration, but rather with echocardiography. And here's an example during a transcatheter edge-to-edge repair where co-registration was made with the TE probe to allow overlay of color flow imaging on the fluoroscopy image, and you can see the clip device being delivered here. This is exciting technology that has continued to be applied to a variety of structural heart disease, but I think this example during a clip procedure was fantastic. Again, it demonstrates how important co-registration to a finite object is, and in this case, the head of the TE probe. And so you can see that in the green here. Other applications of fusion? Well, in our institution, we do a fair amount of left atrial appendage occlusion, and we use uniformly CT for planning. We use CT to assess the morphology, identify the landing zone, size it, and determine the depth of the appendage. And then we also use it to exclude thrombus. In this case, a Watchman Flex device, but you can see examples of measurements that we make on CT looking at the appendage landing zone and the depth of the appendage in multiplane reformat. This is an example of the landing zone here. So that same multiplane reformatting can be applied in 3D echo for appendage occlusion. And you can see here a 3D multiplanar reformat where we identified the landing zone and made measurements to size the potential device. And in this case, 3D echo being its rendering mode of choice post-deployment, you can see the appendage occluder tucked away nicely into the left atrial appendage. So we looked at our experience with fused cardiac imaging and said, oh, how can we take this innovative technique and apply it to this procedure, left atrial appendage occlusion? And we actually published some initial work on this last year, where we took the 3D echocardiography and the CT, which we did for planning, and fused those two data sets at the time of the procedure. One to help guide the delivery sheath, but the other to confirm device positioning at the landing zone. And you can see here these blue dots are sites of co-registration that are common elements along the mitral annulus, as well as the Coumadin ridge, which we've labeled AO to trick the software. And they allow us to register these common elements between 3D echocardiography and the CT imaging. We were able to confirm after delivery of the device that it was seated at the landing zone, not at the true ostium, and that we had delivered it into the correct lobe. So in this initial experience that we published, we were able to highlight some potential applications for CT fusion in the case of left atrial appendage occlusion. And we hope to investigate this further in the coming years as well, as this technology, this innovative technology of fusing multiple imaging modalities really comes to the forefront. So hopefully, I showed you some innovations that you're very familiar with in terms of myocardial mechanics and strain imaging, but then I showed you some that you might not be as familiar with, and you can see applications and how we could take advantage of these technologies in the coming years as well, both clinically and on the research fronts, blood speckle imaging and different types of fused cardiac imaging. I thank you again for your attention. if you have any questions, feel free to email me or reach me on social media, Twitter at PraveenPA. Thank you again.
Thanks, Professor Patel, for excellent lecture. We understand more about how to fuse different techniques of cardiac imaging. Now I would like to introduce my colleague, Dr. Hoài Nguyen. She's from Heart Institute of Bạch Mã Hospital. She also vice chief president of president of Department of Internal Medicine of National University School of Medicine. Today, Dr. Hoài will talk about update in echocardiography in competitive athlete, role of multimodality cardiac imaging. Dr. Hoài, please.
Thank you very much for your kind introduction. Dear professors, dear colleagues, ladies and gentlemen, thank you very much for having me this wonderful meeting. I am Hoài Nguyen from Vietnam. Today, I'm going to give you an update on echocardiography in competitive athletes, the roles of multimodality cardiac imaging. I have no disclosure. Before starting the talk, I'd like to say expanded concept of sport cardiology. This is a review by Aaron Bachi and others that developed a core curriculum for providing cardiovascular care to competitive athletes. And if you are a highly active person, you are also under sport cardiology umbrella, although you are not on a team or you are not competing for a trophy. Competitive athletes are a rapidly growing population worldwide. Habitually, vigorous exercise, a defining characteristic of this population, is a potent stimulus for adaptive structural and functional cardiac remodeling and is an effective way to reduce cardiovascular risk. However, present with active athletes with significant cardiac disease is relatively limited. People with various forms of heart disease still might play sport. People might develop heart disease despite being athletes. And we always ask the question, can sport participation cause heart disease? So far, we have no randomized clinical trial or large case series. We only have anecdotal data only. And there are two things. First, athletes often exhibit little common sense regarding risk. Second, for them, performance, not health, is often their primary objective. So rather than pushing forward, sometimes we need to hold the patients back. This is frequently true of athletes with cardiac condition. When we talk about athletic heart, we always think of exercise-induced cardiac remodeling. It produces volume overload, both atrial and ventricular dilation, greater in the right side than in the left side because the right-sided structure are thinner. Second, the pressure overload that you get from the high level of physical activity produces atrial and ventricular hypertrophy, particularly left ventricular hypertrophy. This in turn lead to ST and T-wave abnormality. Here are some data from Dr. Marons showing the changes in NV size and NV wall thickness with different types of spots. We also see an increased vagal tone in athletes, which produce bradycardia, heart loss, and arrhythmia. And this slide, you can see a composite of 3 studies demonstrating a strong relationship between cardiac mass, cardiac volume, and fitness measures as total oxygen consumption. So the bigger the heart is, the more blood is pumped to the circulation. The primary goal of imaging in clinical assessment of competitive athletes is to diagnose or exclude cardiovascular conditions that are associated with adverse outcome or the symptoms that impede athlete performance or impede their quality of life. So in 2020, ASCI, in collaboration with SCCT and SCMR, has released a recommendation on sport, on competitive athletes imaging by Dr. Bajis A.O. And he discussed about cardiovascular adaptation to routine to moderate to high intensity exercise and differential diagnosis of abnormal imaging findings among competitive athletes and implementation and interpretation of multimodality imaging for competitive athletes. In this slide, you can see the overview of clinical team approach to the assessment and management of competitive athletes with cardiovascular disease. Emphasis is placed on the role of cardiovascular specialists, including multimodality imaging experts and non-cardiovascular internal medicine subspecialists in the care of competitive athletes with suspected or confirmed cardiovascular disease. And you can see in this slide, imaging also play an important role in risk stratification and surveillance following disease diagnosis, including echocardiography, especially transthoracic echocardiography, which is very inexpensive, which is accessible and portable. You can see in the two pictures, Dr. Rebecca Han and Dr. Jose Banch examining patients in a village in a rural area in Vietnam. So you can see that it is very easy to access. Besides, we have advanced imaging technology like a CT scanner and cardiac MRI, which has ability to characterize MV and RV morphology and characterize ventricular tissue composition, as well as visualize the coronary artery anatomy and also visualize extracardiac structure. So when we talk about, when we think about exercise-induced cardiac remodeling, we think this is a classic concept of remodeling. It is very similar to aortic regurgitation and aortic stenosis mechanism. When the MV has the volume stress, it will dilate, and when it has the pressure stress, it will thicken. And we have two types of sport. Sorry. Endurance activity like skiing, like walking, running, or rowing, in which the athlete often have sustained increased cardiac output with a high heart rate, with augmented stroke volume and vasodilation, so they have volume challenge. On the other side, strength activity like a football, like a weightlifting, often cause increased systolic blood pressure and skeletal muscle contraction and vasoconstriction, so it causes pressure challenge. So from left to right, you can see that there are different kinds of sport. With a sport like a badminton, cross-country skiing, race walking, running, saucer, you can have increasing dynamic component, which can cause the dilatation of the MV and RV, and other type of sport like sailing, rope climbing, weightlifting, gymnastics. It causes the increasing static components, and it will make the heart more concentric. And if they are combined, you will have eccentric hypertrophy plus RV and NV dilation. It is a two study from Italian subject, showing that the parameter of NV wall thickness and NV chamber size are in normal distribution. And if we take the cutoff of 20% or 50% here, you can see that we will have a gray zone here in which it is hard to differentiate it between normality and pathology. And this is a study from Dr. Andrea from Italia. She showed that endurance trained athletes had significant greater dry heart measurement than strength athletes and control. This should be considered as a physiologic phenomenon when evaluating athletes for sport eligibility. RV dilation attributable for exercise-induced cardiac remodeling occur in endurance training athletes and must be differentiated from pathologic conditions like arrhythmogenic RV cardiomyopathy, toxic cardiomyopathy, primary or secondary hypertension, and congenital heart disease. This is another study from United Kingdom, also tell us the same. And we can see that there are many studies on left ventricular and diastolic internal dimension. And it tells us that if we want to say the one athlete is normal or not, we should ask them which country he is from, which sport he is playing. Is he male? What is the gender of the athlete, and how old he or she is? Because it is very different. You can see that a female collegiate team sport has end diastolic internal dimension of about 47 millimeters, while a male Dutch national cyclist has a 60 millimeter end diastolic internal dimension. It is the same with the wall thickness. A female Italian athlete has an average 8 millimeter of wall thickness, but the American Olympic rower has much thicker wall thickness of the ventricle. It is a thoracic echocardiographic imaging from a healthy, competitive endurance sport athlete, and you can see that with endurance sport, she has the enlarged NV chamber. It means that she has excess of the volume, and in the parasternal long axis view and also in the apical four-chamber view, you can see both chambers are enlarged. And for diastolic function, you can see that the E-way is very high and the relaxation time is very short. It means that the heart have to, it means that the early diastolic filling phase is very short to respond to the training of the athlete. On the other side, this is an echocardiographic imaging from a healthy, asymptomatic, competitive, strength sport athlete. And he has hypertrophic NV, and you can see the left ventricle, the septum is thickened and the posterior wall is thickened. And he has early diastolic dilation velocity, and E prime is prominent. So what is the difference between physiology and pathology in the athlete's heart? And when you look at the athlete's heart, you may find that he or she may have a thick NV wall, may have a dilated NV chamber, or combined dilated and hypertrophic left ventricle, or he or she may have hypertrabeculation. First, you have to search for clinical factor, like what kind of sport he or she is playing. is isometric or isotonic? What is his ethnic? What about the gender of the athlete? Other symptoms? What about blood pressure and family history? And we look at the 20-grid ECG. And we should look for differential diagnosis like hypertrophic cardiomyopathy, hypertensive heart disease, other infiltrative heart disease, or valvular heart disease. And in the investigation for the wall thicken, we have to avoid some pitfall. For example, NV wall thickening attributable to exercise-induced cardiac remodeling is typically mild, and it is not likely to ascend to over 13 mm in Caucasian and up to 15 mm in black athletes. But if we see the cutting point is rise, we should suspect that the patient has pathologic NV remodeling. And also, when we measure the wall thickness at the parasternal long axis view, we should be very careful to avoid inclusion of RV septum, trabeculation, or posterolateral caudal tissue. And if the patient has a thickened wall and the patient has a diastolic dysfunction or reduced longitudinal strain or have enlarged NA or RA, we should suspect for pathology of NV remodeling. And if we do not find any etiology and we still suspect, we should send the patient to cardiac MR. This is another example of we make a mistake while measuring. And you can see it is easy to make a mistake when we include papillary or caudal to the wall, the postal wall. And how about dilated NV chamber? Often, initial characterization of NV chamber volume should be performed using transthoracic echocardiography. Among the athletes with suspected pathologic dilation, cardiac MR should be performed to confirm dilation and, more important, to characterize structure and function of the NV and other chamber. And also, we should integrate clinical history, myocardial function, and additional diagnostic testing that are generally required for the purpose. And low normal to mildly reduced EF is in asymptomatic athletes with NV dilation are common and can be considered physiologic when accompanied by a normal EDC of diastolic function and concomitant of dilation of the RV and both atria. This is the ECG of an endurance athlete with the blood pressure 140/90, and we can see that he has hypertrophy, NV hypertrophy. And in the echocardiogram, you can see he has enlarged NV chamber and RV chamber. Sometimes we find it is difficult because they are treating overlap athlete heart, hypertensive heart disease, and hypertrophic cardiomyopathy. So in many cases, we have to look at if the patient has a enlarged NA, has a reduced NA strain, or has a reduced NV strain. He or she may have pathology of hypertensive cardiomyopathy, and if the strain if she has the resonance strain that has decreased, we should think of hypertrophic cardiomyopathy, and especially in hypertrophic cardiomyopathy, the patient may have mechanical disparity we can find in strain. And for RV dilation is always conjunction with NV dilation and is common among endurance trained athletes. Physiologic dilation of the RV should occur without structural and functional RV abnormality. And if we find if we find any difficulty with TTE, we should send the patient to cardiac MR. For hypertrabeculation of the NV and or RV is often seen at the apex with normal wall thickness is common among competitive athletes. It is suggested that the increased preload in isotonic physiology stimulates trabecular enlargement. And physiologic hypertrabeculation of the apex is common among symptomatic athletes, and it is often observed in black or endurance sport athletes. And physiologic hypertrabeculation should be accompanied by normal NV wall thickness or normal indices of NV systolic and diastolic function. While the non-compulsion cardiomyopathy we often see with reduced systolic function and diastolic function. TTE often requiring the addition of contrast agent for image optimization represent first-line imaging for characterization of NV hypertrabeculation among athletes. If we are not sure, we can send the patient to cardiac MR. And it is the autopathy. In athletes, there are mild dilation of aortic root seen in the study, but the rate of aortic root that is dilated more than 40 millimeters for male and more than 34 millimeters for women is just 0.5 to 1.8%. And also, there are some measurements that we make during different phases of cardiac cycle will result in different value. This is multimodality aortic imaging in the competitive athletes with an ascending autopathy. On the left side, you can see on parasternal long axis view of echo, you can see the enlarged ascending aorta. And on the right side is the cardiac MR angiography. We can see that he or she has an aneurysmal dilation confined to ascending aorta, but the descending aorta is normal. And this is the slide about anomalous coronary. This picture showing an image from pediatric athletes presenting with chest pain and near syncope found to have an underlying high-risk anomalous coronary artery. Transthoracic echocardiographic parasternal shock axis view demonstrating a left anterior left coronary origin feeding along left main coronary artery crossing between aorta and pulmonary artery. And we can see from color Doppler imaging demonstrating diastolic flow in the proximal left coronary artery. We use CT imaging with 3D reconstruction to confirm the origin and proximal cause of high-risk anomalous left coronary artery. And what about pre-participation? We know that pre-participation for cardiovascular disease is very important of athletes that we find the associated disease that increase the risk of sudden death of the athletes. In the picture, I think that all of you know who is he. He is Christian Eriksen, the soccer player of Denmark team, and in May 25th of May, his team played with Finland team, and he fell down and he had cardiac arrest, and now he has the implant with an ICD. And this lady is Miss Vietnam. She has a marathoner as well, but we lost her 1 month ago while she was running. So there are many common causes for sudden cardiac death, and it relates to exhaustion symptom in competitive athletes. It is disorder of myocardium, cardiac structure, and disorder of cardiac electrical system, or coronary circulation, or valve disease, or disorder of the aorta, etc. But what is the standard of care? It is still controversial. According to American guideline, the US guideline based on medical history, family history, and physical examination. And when there are some findings, 20 lead ECG was indicated. And if there are some findings, we can indicate the patient to have echo or other imaging. And in Europe, ECG was included in standard of care for screening for athlete of pre-participation. So for pre-participation screening, routine participation screening of young athletes should include a focused personal and medical history and physical examination. The addition of 12 leads ECG may be considered in situations with adequate financial resource and clinical expertise. The use of non-invasive imaging, including comprehensive and limited thoracic echo, CTA, or CMR, is not recommended as a first-line strategy during pre-participation screening. And the program should ensure timely access to clinical center with sport cardiology and clinical imaging expertise to facilitate comprehensive multimodality imaging required to evaluate findings detected during pre-participation screening. And in the guideline in 2020, ASCI recommended that we start with medical history finding, physical examination finding, and physiologic ECG finding. Then if there is any abnormality, we can do TTE, and if the TTE is inconclusive, or if we find any pathology, we can send the patient to cardiac MI, cardiac CT, and other exercise imaging. If we exclude any all the pathology, we do not do any more testing. And how about evaluation the symptomatic athletes? We often have a symptom like a chest pain. With chest pain, TTE should be performed as initial non-invasive imaging test, and we should do exercise testing as well. But we should be cautious because in athletes, he or she often have rapid heart rate recovery. So if we render imaging non-diastolic for evaluation ischemia, we often have form negative. And TTE imaging in athlete with possible or portable cardiac chest pain should include careful and definitive delineation of both left and right coronary origin and proximal cause to exclude anomalous coronary circulation. If we are unsure, we can send the patient to CMR or get CTA. And about syncope, if the syncope happens post-exercise or is unrelated to exercise, it is common among athletes, and it does not require any more evaluation with any non-invasive imaging modality. But if the syncope happens during exercise, we should undergo comprehensive multimodality imaging, beginning with thoracic echo and extending on the case-by-case basis to CTA or CMR to exclude structural and valvular heart disease as a part of comprehensive evaluation. We can consider exercise testing with and without imaging About palpitation and arrhythmia, competitive athletes presenting with palpitation or subjective arrhythmia that occur or intensify during exercise should undergo TTE to diagnose or to exclude underlying structural disease. And athletes presenting with palpitation or subjective arrhythmia that occur or intensify during exercise should undergo exercise testing. And all competitive athletes undergoing evaluation for ventricular pre-excitation, both asymptomatic or symptomatic, should undergo TTE to exclude concomitant absent anomaly and other hypertrophic cardiomyopathy or complex form of congenital heart disease. And what about exertional dyspnea? For inappropriate exertional dyspnea, it may occur in the context of numerous cardiovascular disease. So comprehensive TTE should be performed in athletes presenting with inappropriate exertional dyspnea and in athletes with previous diagnosed non-cardiac cause of inappropriate exertional dyspnea who do not demonstrate adequate response to therapy. And exercise testing should be considered to indicate for the patient. And the last symptom, the last thing is athlete performance decrement. This is a very complicated thing because we should consider many aspects like a sleep, like a diet, like a exercise, like a stress, like a healthcare, hygiene, and sometimes we have to look out of the box. And TTE should be performed for athletes presenting with athlete performance decrement when medical history, physical examination, traveling electrocardiography, or routine blood tests yield one or more findings suggestive of myocardial, coronary, or valvular pathology, or when no clear explanation can be ascertained from the initial evaluation. The use of exercise testing and CTA and MRI imaging should be considered on a case-by-case basis among athletes presenting with athlete performance as dictated by suspected or confirmed pathology. And we have the other group. First is master level of competitive athletes. And in this group, the participants often older than 35 or 40-year-old, and this number of the population is the population of master level competitive athletes is growing worldwide because people want to take exercise, to want to do sport. And the common cardiac cause of morbidity and mortality in master level competitive athletes are atherosclerotic coronary disease, AFib, and degeneration, aortic mitral valve disease, hypertensive disease. And what about pediatric athletes? Many of the key cardiac conditions associated with increased risk of sudden death during sport become clinically apparent during this early period. But today there are little data documenting exercise-induced cardiac remodeling in pre and early adolescence competitive athletes. And hypertrophy chamber dilation might occur at a lesser magnitude than that typical in adult. And we have some challenges in differentiation, normal physiology and pathology because we have because it is difficult to distinguish between the because we have a limited and compounded by standard pediatric practice use the body surface area normalized cardiovascular measurement. And what about the congenital heart disease? Dramatic advances in the management of patients with congenital heart disease with increasing recognition of the health benefits of routine exercise have led to increase in the number of athletes. However, the safety of competitive sport is still unclear. It is almost now so far we just know that congenital malformation, severity of malformation, prior and ongoing therapeutic intervention, and the volume and intensity of sport participation may play an important role in the prognosis of the patient. So conclusion, a carefully constructed multimodality imaging strategy has potential to diagnose and risk stratify athletes with cardiovascular disease and to exclude the presence of disease to permit safe unrestricted competition. Optimal use of multimodality imaging in competitive athletes requires both an understanding of exercise-induced cardiac remodeling and the strengths and the weakness of available imaging technique. TTE should be considered the first-line imaging modality in athletes with suspected pathology. Cardiac CT, cardiac MR, and exercise testing with imaging provide complementary data, and their use should be considered in the cases of suspected or confirmed pathology. Differentiating exercise-induced cardiac remodeling from mild forms of pathology remains challenging in clinical practice and in corollary data in specific groups, including children and people with congenital heart disease and are spared. Further acquisition of normative data, particularly data derived from CMR and CTA, may further address this important contemporary clinical challenge. Thank you very much for your attention.
That was wonderful. Thank you so much, Dr. Y. I have one question that I would like to pose to both you and to Professor Lai, if possible. You mentioned in your presentation that we need to consider a patient's and an athlete's ethnicity in terms of the measurements. It strikes me that we need to know more about Asian athletes and the data that may or may not be out there, and apply that to our considerations in imaging athletes. So I was wondering if both of you could comment on that.
I might answer. We in the United States did a study looking at African Americans versus Caucasian children, and found that the body surface area was probably more important than the race. But there are certainly adult data that show that ethnicity is a major factor when talking about sizes of structures, and I suppose that will be the case when we have large enough data sets. And when we look at data sets from being submitted from various parts of the world, we do see differences. So I think your point's well taken, that when we are looking to risk stratify, we should use the best data from a local or from the same population that the patient is from.
Thank you. We do not have the data in Vietnam or in Southeast Asia, but there are some study in Japan, and they found a small prevalence of cardiac sudden death in young and in adolescents, and it relates to arrhythmia and long QT syndrome and some other ECG abnormalities syndrome.
Thank you for the question from Dr. Kirkpatrick. But why do you think that our society need to do a basic echocardiography for Vietnamese elect? Do you think?
Yes, that is a
Maybe we
great
can
idea.
organize
Yes.
with the help of Dr. Kirkpatrick and Dr. Lai.
Yes, that's a great idea.
I think this may call for the role too of the use of these small portable ultrasound devices that were mentioned by a number of our speakers in helping to identify people. We have a number of programs using these devices that go out to schools and screen patients. They don't screen all patients, but again, following the guidelines that you so expertly elucidated, only those who have a suspicion of having something. But I think it's very helpful to be able to get the imaging test at the point of evaluation, rather than having to have a referral for a follow-up test later on, because that may not actually happen.
Mm.
Well, Professor Lai, was very intrigued by your initial data looking at artificial intelligence in and applying it to pediatric cardiology. That is just phenomenal work. I was hoping that you could comment on how you see this, perhaps when it is robust enough, how this is going to perhaps change the practice of fetal echocardiography, but even of congenital scanning, and especially in relation to who will be doing that scanning now that there will be potentially some artificial intelligence augmentation.
Very good. Well, thank you for that question. It is, I think, already here for fetal echocardiography, because I think the views tend to be more standardized, and the ability to send the network for screening because there's no urgency of treatment, I think that is here. As far as the POCUS, point of care ultrasound for the diagnosis, I think that will be revolutionary too, because in the countryside, in areas where there are no cardiologists, you can provide the local healthcare workers, students, nurses, and maybe anybody where you can have training and supervision. I think that will be also a major thing for screening, and it won't rely on having physicians from the city or from other countries involved in the screening. And I see that coming in the near future because, as you mentioned, point-of-care ultrasound is almost readily available everywhere, and its cost is coming down, and I think that, along with AI-guided examinations, where I didn't show it, but now you have systems where you can actually have a image on this system where the operator is now taught or guided to obtaining the accurate, the image that's necessary for assessment of the heart. And so I think that is coming too. I don't know if others have had this experience, Jim. Certainly maybe you have in Seattle. I was very impressed with some of the technology that I saw in Vietnam already, and I think that it will be here soon too.
Yeah, we were very excited about this, using this technology during the worst part of the pandemic in particular, because if a novice user had to go in and examine a patient who was infected and could get adequate images that could be interpreted either with the help of artificial intelligence or by someone else who's watching remotely, as long as they could get those good images, then wouldn't necessarily have to have someone else come into the room and be exposed. So I think this does have great potential. We ended up not having that many cases, so we never actually used it that much. But I think that depending on what happens with this and other pandemics, it could be a very, very important thing just to reduce the spread and exposure in the hospital setting. But I would love to hear what Professor Vin and Dr. Y have to say about this too.
I think now we must solve the problem of pandemic. Now I must do much for in our hospital. We must prepare for something to explanation for the patient about vaccine, about how to treat the patient online. We need a patient test online. And so in our hospital, we restrict to do echocardiography. I asked for our young doctor to do echocardiography with PPA, the robe for protection of the young doctor. So I think that in the future, we need to do more sample echo and can help the patient in scale pandemic to stay better for protection of medical health care person. Now this, since this 3 months, when we have a big pandemic in Ho Chi Minh City, I understand more the situation in Seattle, in LA and United States before last year. In Hanoi, why? Up to now, you have no experience about this.
Yes, the situation is still under control in Hanoi. Yes. But we also share the difficulty with our college in Ho Chi Minh City and in Bình Dương and other southern province. We send many doctors and nurses and send equipment to the south, and we hope that it can help a little bit.
Yeah, and we certainly have heard that is a similar situation in many countries in Asia, and our hearts go out to you as well. That obviously is happening in the United States as well, in certain of our southern states, primarily where people are not agreeing to be vaccinated. And we know that it's very different because you don't have the same access to vaccines that we do. But we're ending up in a similar situation because of that. But I also would like to turn to some of the questions that come up in relation to these very novel techniques that we saw demonstrated today. I think in particular with the speckle tracking flow that Dr. Patil illustrated. What role do you think that this might have in the future in imaging patients in Asia, particularly where perhaps there is not as much access to cardiac MRI, or perhaps there are cardiac MRI machines and they're very top of the line, but they are so many patients that you still have to restrict it. Do you think that this might have a role similar to what we would be able to accomplish with some of the higher end MRI techniques in settings which don't have as much MRI?
Yes, we hope so. We hope that blood spectrum tracking will be could be put into practice, and with its development of the technique, sometimes we can use instead of cardiac MRI. But now in Vietnam, I use this technique just for pediatric patients, not yet for the adults. Yeah.
Yeah, it strikes me, and I don't know, Lyman, if you have seen this technique used to examine some of the flow techniques. I wonder if looking at baffle flow and some other things that this might actually prove useful.
Yeah, well, unfortunately, it is a very useful technique by MRI in our single ventricle patients, where we are doing a lot of energy analysis, energy loss analysis in our fontaines. but because of the limitations of windows for those baffles in the lungs, I think MRI really is the ideal tool. And I don't know that echo, as much as it is useful to look at, and maybe we can understand the physiology better, I don't know that echo can at least replace it in the most useful place right now. Looking forward into the future, I would think it's going to be more use in adult heart disease assessment, but that's just a guess right now.
The other striking presentation was in the fusion imaging, and fusing pretty much every modality at this point, maybe with the exception of nuclear, but all of the other techniques to guide procedures. Do you see other applications for fusion imaging sort of outside of the procedural lab or the operating room? One thing that occurs to me is that if we are able to fuse some of the particularly CT anatomic data with our echo data, I think this could be diagnostic as well as guiding procedural interventions and making measurements. I think it also might show us sort of the discrepancies between our CT measurements that we get off of, at this point, static images. And it's true that they are ECG gated, but they're still static. And the motion that can actually occur, which is seen very, very well by echo, that might sort of point to some of the issues with using static measurements and suggest that we do need to fuse these modalities and see how much change there is throughout the cardiac and sometimes even the respiratory cycles.
Mm-hmm.
Well, one further question that I have, and I obviously would love to hear any more questions from Professor Vin, but what sort of immediate impact do you think that valvular imaging that Dr. Riglin in particular discussed in the very first lecture, what impacts do these things have on practice in the Asian context, and particularly the Vietnamese context? Do you sort of see valvular imaging here primarily focused on rheumatic heart disease, or do you think that it's kind of moved beyond that and in a way multimodality imaging of all of the valves is becoming increasingly important in Asia?
You know that when I began to work in Heart Institute of Carpentier in the year of 1991, after in nearly 10 years, we only have echocardiography for surgery of valvular disease and also congenital disease. But after that, we have CT, we have MRI. But I think that now we need to have multi-modality imaging for helping the patient with valvular disease. The rheumatic valvular disease in Vietnam we have so many degenerative valvular disease. We also have some problem as in Western country, bicuspid aortic valve, degenerative mitral regurgitation, and so rare rheumatic valvular disease. Maybe we have decrease of pharyngitis, streptococcal pharyngitis, and so decrease. So I think in future, if you would like to see some rheumatic valvular disease, we need to go to another country, maybe Africa, But in Vietnam, in Thailand, or in Malaysia, we have not much rheumatic valvular disease. But I think that echocardiography help us so much to detect valvular disease to help the young person and the children.
I agree with Professor Wing, and we also found that rheumatic disease is very rare now in Vietnam. It demonstrates the effort of elimination of rheumatic disease in Vietnam.
In the future, we can meet each other party. Thank you very much.
Thank you. Thank you so much, professors. It's a wonderful afternoon. Really wonderful. Thank you so much.
Thank you.
Thank you.
Greater insight, increased confidence, and better teamwork. EPIC offers a dedicated solution for real-time fusion. You want an ultrasound system that Philips, innovation and